Yes, thank you very much for the introduction. First of all, I would like to thank the organizers for inviting me. Today I was supposed to talk about integrating biomarker application into clinical routine. So as I only have 50 minutes, I slightly changed the title of the talk. So I will talk about biomarker-guided implementation of the KDIGO guidelines to prevent AKI after cardiac surgery. So acute kidney injury is a common complication in hospitalized patients. The most common cause of AKI is surgery, as you can see here, approximately 50%, and the second most frequent form of AKI is major surgery. If you look at all surgical procedures, we see that AKI is a common complication after cardiac surgery. So this retrospective study demonstrated that approximately 25% of all patients undergoing cardiac surgery develop an acute kidney injury. Most of the patients develop a mild acute kidney injury, whereas 5 to 8% develop a moderate or severe acute kidney injury. Furthermore, the authors demonstrated that the development of an acute kidney injury is associated with an increased mortality. So patients who developed a severe AKI had a mortality up to 45%. And the authors also calculated the odds ratio for the mortality. This was 5.3 per one stage increase. In the last couple of years, several studies have been performed investigating different measures to treat acute kidney injury, however, without any success. So there is no specific therapy available yet. One possible explanation for this is that the therapy was always started too late. So the KDIGO guidelines suggest that different measures should be started in patients at high risk. And these measures include to discontinue nephrotoxic agents, to optimize the volume status, to optimize the perfusion pressure, to monitor serum creatinine and urine output, and to avoid hyperglycemia. The acute kidney injury is a continuum that starts with an increased susceptibility and ends with an organ failure. So an increased risk and kidney damage are clinically silent. If we have a progression of the disease, the GFR decreases and the end stage is the organ failure. To diagnose the golden hour of AKI, that means patients at increased risk and kidney damage, we need biomarkers. And the importance of biomarkers are highlighted in this study, which showed that a kidney damage without a loss of function is important for patients' outcome. So the authors divided the patients into 4 groups based on the serum creatinine level and biomarker levels, and they used NGAL as a biomarker. So, and I want to focus on the first 2 groups. They demonstrated that patients with a normal biomarker level and a normal serum creatinine level had low dialysis and mortality rates. In contrast to this, patients with elevated biomarkers and a normal serum creatinine reflecting a kidney damage without a loss of function had a significantly increased dialysis and mortality rate, suggesting that a kidney damage without a loss of function is clinically important. And based on this study, the term subclinical AKI was introduced, and this was highlighted in this viewpoint. The authors wrote, there's an additional value of new biomarkers, not only because they allow a diagnosis to be made earlier, but also because they allow a kidney injury to be diagnosed even in the absence of subsequent dysfunction. Furthermore, the authors wrote, the term subclinical AKI has been introduced, challenging the traditional view that a kidney problem is clinically relevant only when a loss of filtration function becomes apparent. So nowadays we know a lot of biomarkers, for example, NGAL, IL-18, and many other biomarkers. However, we can only measure 3 biomarkers at the bedside, and this is NGAL and TIM2 and IGFBP7. two biomarkers which were already introduced by John Callum. So here you have already seen the slide. TIM2 and IGFBP7 are involved in the cell cycle arrest, so the cells are normally in a cell cycle, and once they get damaged, they can leave the cell cycle and go into the cell cycle arrest, where they are protected from further damage, and they have enough time to recover, and once they recover, they can go back into the cell cycle. So that's also true for renal tubular cells. IGFBP7 and TIM2 may also signal in an autocrine and paracrine fashion, so spreading the alarm signal from the site of injury. These are the results of the Sapphire trial. In this trial, the authors discovered TIM2 and IGFBP7 as renal biomarkers and validated these biomarkers in a large observational trial. The primary outcome parameter was moderate or severe AKI. And here you see that TIM2 and that the performance of TIM2 and IGFBP7 was better compared to the performance of other known biomarkers, for example, NGAL, cystatin C, KIM1, and so on. We also used these biomarkers in order to investigate whether we can predict an acute kidney injury after cardiac surgery, but we focused on high-risk patients. So in order to identify these high-risk patients, we used the Cleveland Clinical Foundation score, and this score consists of different risk factors, and for each risk factor, you get a certain amount of points. And the number of points you get in this score correlates with a dialysis-dependent acute kidney injury. And we measured TIM2 and IGFBP7 before surgery, 4 hours, 12 hours, and 24 hours after cardiac surgery. And here you can see the composite value. That means the highest value within the first 24 hours, and the area under the curve for TIM2 and IGFBP7 was excellent, was 0.896. However, if you only want to measure these biomarkers once, you should measure them 4 hours after cardiac surgery. Here, the area under the curve for TIM2 and IGFBP7 was 0.805. And the area under the curve for NGAL was only 0.679. So biomarkers can predict the development of an acute kidney injury. However, if we measure biomarkers in an unselected patient population, the specificity goes down. So that means if we measure troponin I in all our ICU patients, we will find patients with an elevated troponin I. Also, they haven't suffered from acute myocardial infarction. As acute kidney injury is not painful and we often don't know when the injury occurs, the term renal angina was introduced in 2010. So this concept consists of different risk factors and a clinical scenario, for example, patient with sepsis and or patients undergoing major surgery. And if we have such patient with a certain risk factors and clinical condition, we should measure biomarkers. And if these biomarkers are elevated in these high-risk patients, we can start a more invasive therapy. For example, we can start renal replacement therapy. And we use this concept in one of our trials. This is a biomarker-guided implementation of the KDIGO guideline to prevent acute kidney injury after cardiac surgery trial. So we called this trial PREVACI trial. This is a single-center randomized controlled trial. We recruited the patients in Münster, and we started the recruitment in September 2014, and we finished the recruitment in January 2016. Here you see the inclusion criteria. This was age between 18 and 19 years. All patients undergoing cardiac surgery with the use of cardiopulmonary bypass, and TIM2 and IGFBP7 concentration equal to or higher than 0.3 4 hours after cardiopulmonary bypass. Here you see the exclusion criteria. So we excluded patients with a chronic kidney disease not requiring renal replacement therapy. We defined this as a GFR below 30 mL per minute, patient with a pre-existing AKI, and glomerulonephritis, interstitial nephritis, and vasculitis, pregnancy, and patients after kidney transplantation. Here you see the study flow. So we screened all patients undergoing cardiac surgery, and we measured TIM2 and IGFBP7 4 hours after cardiac surgery. And if the value was equal to or higher than 0.3, we randomized the patient into a control group, as you can see here on the left side. They received the standard of care therapy, so we tried to keep the mean arterial pressure above 65 millimeter of mercury and the central venous pressure between 8 and 10 millimeter of mercury. And the intervention group, and this intervention group consisted of the KDIGO recommendations. So we tried to discontinue all nephrotoxic agent when possible. We tried to optimize the hemodynamic, and we developed an algorithm for this. I will show you the algorithm on the next slide. We monitored serum creatinine and urine output, avoid hyperglycemia, and consider alternatives to radio contrast procedures. And here you see the hemodynamic algorithm. So we first of all looked for the stroke volume variation. If this was higher than 12, we gave volume. And in the next step, we looked for the cardiac index. If this was too low, we gave inotropes. And in the last step, we looked for the mean arterial pressure, and we tried to keep the mean arterial pressure above 65. If this wasn't the case, we gave vasopressors. And once we achieved the goal, we checked every 3 hours up to 12 hours after randomization. If we didn't achieve the goal, we started from scratch. So the primary hypothesis was biomarker-guided implementation of the KDIGO guidelines reduces the occurrence of acute kidney injury after cardiac surgery. The primary outcome was the occurrence of AKI within the first 72 hours after cardiac surgery, and we used the KDIGO criteria to diagnose and stage AKI. Secondary outcomes were severe AKI, that means moderate and severe AKI within 72 hours, mortality after 30, 60, and 90 days, renal recovery, length of ICU and hospital stay, and major adverse kidney events at day 30 and 90. So before performing this trial, we did a power analysis, and based on our published study, we assumed that approximately 80% of all the patients with a TIM2 and IGFBP7 value above 0.3 develop an acute kidney injury. We wanted to reduce the occurrence of AKI from 80 to 65%. That means that we had to recruit 138 patients per group. And here you see the preliminary results after recruiting 50 patients. You see that the biomarker-guided implementation of the KDIGO guidelines after cardiac surgery can significantly reduce the occurrence of moderate and severe AKI. And this p-value was already significant after recruiting 50 patients. And before I summarize, I would like to show you one case from this study. That was patient 35. This is a 72-year-old female. The primary diagnosis was 3-vessel CAD with mitral valve regurgitation. Secondary diagnosis was chronic heart failure with a reduced ejection fraction, arterial hypertension, and CKD. The procedure was a three-vessel CABG and mitral valve reconstruction. The cardiopulmonary bypass time was 102 minutes, and aortic cross-clamp time was 60 minutes. So here you see the postoperative hemodynamic parameters. The blood pressure was fine, was 120 above 74. Heart rate was 80. Central venous pressure was 8 millimeter of mercury, and the patient received a low dose of norepinephrine, and lactate was also fine. So 4 hours after cardiac surgery, we measured TIM2 and IGFBP7, and the value was 0.56. So we randomized the patient, and the patient was randomized into the intervention group. So we inserted a PICO catheter within 1 hour after the first measurement, and we measured the stroke volume variation. So This was 14, this was above 12, so we gave volume. And after this, after giving volume, we measured again, and the stroke volume variation was 10. This was fine, but the cardiac index was too low with 2.4 liter per minute. But the blood pressure and lactate was good, so we gave inotropes. And then we measured again, and here in this measurement, the stroke volume variation, cardiac index, as well as the blood pressure was fine. And I can tell you that this patient didn't develop an acute kidney injury. So that I can conclude, subclinical AKI worsens outcome, so a kidney damage without a loss of function influences patient's outcome. Biomarkers can identify patients at high risk for acute kidney injury, and they can also detect kidney damage. Treatment should be started early, so when kidney injury occurs, or even earlier, so in patients at high risk. Our preliminary data suggests that biomarker-guided implementation of supportive measures reduces the occurrence of acute kidney injury after cardiac surgery. Thank you very much for your attention.